Everybody can hear me? Okay, great. So first of all, I just wanted to say thank you all for taking your time, and I'm sorry to get out of clinic a little bit late. Then I keep forgetting. Anybody live in Española? Anybody know so you know we're down from 3 bridges to 2, and then we got all that construction going, and if you don't think in advance of getting someplace an early start, you're in a bind there. Anyway, just a little bit about myself, but first I want to say thank you all for the great work that you're doing and your interest in this topic. I've just been so impressed, not only with the interest with your group, but also the persistence. I mean, really, the endurance, yeah. Okay, all right. You don't have one of those clip-on things, do you? I love those. No? Oh, I'd like a clip-on. Yeah, if I get a clip-on. So just a little bit about myself. So I'm Eric Ketcham. I'm an emergency physician by training. I've been doing mostly addiction medicine for about the last 8 years or so. I joined Presbyterian about almost 7 years ago. And I joined Presbyterian. I was recruited as an emergency physician to help staff their new hospital, not so new now, but down in Santa Fe. But I agreed to take the job only if I could do half-time addiction medicine, and I know I was charged with essentially expanding the addiction medicine consult service up to Santa Fe Medical Center and to Espanola Hospital. I've enjoyed working at Espanola Hospital the most, and I was able eventually to move all my work up to Espanola Hospital. So that's kind of me in the area here.
This goes right in your ear, and this goes hooks onto something.
Oh, these are fancy stuff you all got here. So, make sure I do this right. You guys have great equipment here. Like, I'm so impressed. I guess it's a science town, right? I guess I should expect that. A tech town for sure. So, anyway, how's that? Is that better? Yeah. Oh, good. Okay, so I want to just, people often ask me, well, why did I kind of move from doing emergency medicine? I still am a practicing emergency physician. I used to work up here in Los Alamos. I haven't worked up here in about 3 or 4 months now, but I work in the emergency department at Espanola Hospital. I'm down to working about 3 or 4 night shifts a month, so it's really kind of a quarter FTE of what I do. Then I work a lot of different things doing addiction medicine. But just to tell you, just a very brief story, I was started really getting into this about 2009 in Farmington. I was the medical director of the emergency department at San Juan Regional, and we just had this incredibly growing problem of every day people withdrawing from opioids, and then trying to figure out what to do about this problem, and everybody seeking opioids. And back then it was mostly oxycodone. We hadn't really been hit by heroin yet so much in Farmington. That didn't happen until about 2011 or so. And every day it was just overwhelming. And basically, we had, one of those, we call the Candyman, in town. That's what they did, run a cash clinic, and everybody got a script for oxycodone, unbelievable amounts of it, OxyContin, right? So anyway, I started trying to solve this problem of how do we stop, contributing to it, and how do we start getting people into treatment? And turned out to be more complicated than I thought, and then had to get an X waiver. I had to learn about buprenorphine. I didn't know anything about it. I'll talk about it a little bit here. And then, so we learned to use buprenorphine to treat opioid withdrawal. So we were treating withdrawal so much more effectively, but then we had to connect people to treatment. There was no clinic in town really, right? And then a methadone clinic opened up for a little while, and I was so happy, finally a clinic. And then after about 6 months, they were going to close because they didn't have a physician to staff the clinic. So they came to the hospital, and eventually we agreed to staff the clinic as long as I would do it, of course. So I went over there and started staffing the clinic 1 morning a week. And this is a sad story in my sense that I have to be honest with you. When I first went over to do that, I had like this identity crisis. Like, I was driving up to the clinic, 7 o'clock in the morning. It was this March. It was cold. And I was thinking to myself, what happened to me? Like, just last year, I'd been the chair of the Department of Surgery. I was a big wig at the hospital, really feeling important. And what's become of me? I've become a methadone doctor. Like as if we thought that was like such a low thing. Like, who would do this, right? And And I said, well, I only agreed to do this for 3 months until they hire somebody. I didn't want the place to close. I just needed a place to send people from the hospital. So anyway, I started treating patients, and it was a very sort of humanitarian sort of epiphany. The first few people I started treating, they hadn't had a new doctor in months, right? So everybody shows up, they're really sick, they're throwing up, they're bringing a bucket with them from the people who are homeless, and they look pretty rough. And so I learned how to start people on methadone, initiate methadone, how to adjust dosing, and I'm doing this over the next couple months. And over the next few months, I start seeing all these people coming in the clinic that were just seeing a lot of patients. There was a tremendous unmet need, and I had to expand my hours to keep up with the demand. And I start seeing folks coming in, and I'm thinking, who are all these people so well dressed? And I'm thinking they all must be vendors or they're employees. Like, who are all these people they're hiring or vendors? You know, what is going on? And so I asked the dosing nurse. I said, well, you know, this guy really looked well dressed and neat and clean walking by. I said, who's that? I said, oh, that's Travis. I went, well, Travis who? And every patient has a number. That's the supposed confidentiality you have in a methadone clinic. There's no real confidentiality in a methadone clinic, right? Because everybody's there for one reason. Everybody knows each other. So anyway, I said, Travis. I said, I had to go look him up. And I read his story about it. Well, you know, he was homeless when I started seeing him. And so the next day when I see him in the clinic, I said, Travis, right? He goes, yeah. I said, how are you doing? He's doing, oh, I'm good. I said, what are you doing? Well, I'm the manager of the Verizon store in town. And blah, blah. Like, wow. I think he was like, you know, we had no transportation before. And then the next day, I see this woman walking in. It's just, once again, I think she must be like, maybe she's the new manager. I thought we were hiring a manager, right? And I asked who that is. And they said, oh, well, that's Nicole. And I said, Nicole who? You know, I said, well, they gave me her patient number again. I'm like, okay. So I go and read about her and knew she was also, you know, homeless and kind of living in a broken down car and all the stuff that she was doing. And so I stopped her next time I saw her. I said, so Nicole, right? She says, yes. And I said, Nicole, can you just talk to me for a minute? And I just tell me how you're doing. And so she came to the office and they just sat down and I said, Nicole, just, how are you? And she says, I'm kicking ass in life. You're kicking ass in life. What does that mean? I said, tell me about that. He says, well, you know, I have my own apartment now, and I'm not couch surfing or, you know, sleeping outside anymore, and I've got a steady job. You know, she was a server at Chili's, but she'd actually kept a job for more than a week or so, you know. No longer doing a lot of things she wasn't proud of, and healed a relationship with her family. She was back at school. She was going to school at the San Juan College, which is a local community college, and she wanted to go into nursing. And I was like, it just blew my mind. I'm like, you mean just because you come here each day and get this dose of methadone, and now you have your life back? Like, it's that simple. Like, whoa. Anyway, it was really surprising. So anyway, gradually over the years, I ended up doing more and more addiction medicine, jail medicine for a while, and then I moved here to Santa Fe, I guess in 2017. When I left San Juan Regional. And the reason I left San Juan Regional is that I just couldn't grow an addiction service of any kind. They didn't really want to do it. They didn't have an interest in it. So that's my story. I've been involved in a lot of advocacy work. Got a few bills passed in Congress. Been invited to the White House. Testified before Congress. Done a variety of different things in addiction medicine. Working with detox centers. I work with an adolescent center in Albuquerque. I still work with a detox center in Farmington, one with Hickory Apache. I take calls for the Poison Center for the state of New Mexico, you know, so hospitals can call when they have questions about how do we manage this or that. Mostly it's opioid focused. So I've got my fingers in a lot of pies. I've been trying to pull them out of those pies, really to focus on what we're doing at Espanola Hospital. I will just say that, just my last comment, and I'll roll into this, that I had no idea when I first started working at Espanola Hospital how much I was going to enjoy working there. In fact, my ex-wife, her family is all from Espanola for the last 400 or more years, right? And I've always known it to be a rough town. I used to come visit, and I never thought I would really want to work there. But it just sort of, that's how it evolved. I wound up working there, and it's just a wonderful place to be. So that said, I'll just kind of roll into this, if that's okay. Feel free to interrupt me at any moment if you have a question. I try not to, yawn or yammer on too long about this, okay? But, so we are in the midst of a really robust expansion, and this is really exciting because for several years, the entire addiction medicine service was just me, and then finding ways to educate others so they could, do some work, and then work with some nurse practitioners and get patients started, and they would take over their care. We had to kind of link things together, just find ways to get things done. But now we've launched on this massive expansion, and this is grants that we were able to get, and we were able to earn these grants because we had demonstrated a lot of data to show the progress that we made, the impact we've made, the reduction in hospital readmissions, mortality, et cetera. So anyway, so it's very exciting. So we pulled in a lot of grant money to fund this. Now, some of that grant funding is certainly at risk of the Trump administration kind of taking it away. So we'll get to that. Okay, let me make sure I'm going the right way. Oh, there we go. So I'm just going to briefly touch on the epidemiology of just two of the major substance use disorders that we treat, right? Our clinic, we treat everything. So we treat alcohol use disorder, opioid use disorder, stimulant use disorder, which is mostly methamphetamine and cocaine. We see patients who use ketamine. We treat cannabis use disorder, treat tobacco use disorder, a few other things. Some people who are still using what's called dextromethorphan. It's in cough syrup. So anyway, we're going to talk a little bit about Rio County, kind of in particular, some basic pharmacology. I'm going to keep it simple, and what we're doing in our expansion, our goals and vision, and we have some needs. So I'll talk to you about that. So this is where we are with the opioid epidemic in the United States. This is just through 2022. That green graph, there kind of levels off in 2023, that big one, right? And then it actually, we have preliminary data. We still have preliminary data showing in 2024 we've actually started, statistically significantly have come down. This is national data. The hey, does this have a pointer on it? Oh, it does. So when I was called to testify before the United States Congress, the House Judiciary Committee, about the opioid epidemic, this was in 2016, and back then I was, talking about where we are. And going off of 2015 data, that what a tragedy it is that essentially 100,000 or over 50,000 Americans, were dying now every year because of drug overdose, right? And how terrible that was, but it's double that from what I was saying then. And it really took off here, started around 2016 we started to see fentanyl, and then it just really zoomed up. So we talk about, it says synthetic opioids other than methadone, and that just means methadone is a completely synthetic product. Okay, it was developed in the 1930s. Fentanyl is a completely synthetic product. When we say completely synthetic, it means everything else is one way or another connected to something that comes out of the opium poppy. Most things are derived from morphine, except buprenorphine, which also is connected, but comes from a different chemical. So, interesting, I just want you to note this, right? So, it all really started with prescription opioids, and it wasn't until the early 2000s that finally the CDC is starting to say, Houston, I think we got a problem. And this is because of all the kind of wildly increased prescribing that started in the mid-90s through the aggressive, marketing. You all have heard this story, right? The Sackler family, Purdue Pharmaceutical. Then they somehow got Joint Commission and CMS to buy into all this and develop quality standards to make sure everybody's prescribing lots of opioids. Really, it's ridiculous. And so what we started seeing was this steady increase in overdose deaths related to this. Well, this semi-synthetic opioids, well, it's oxycodone is what that mostly is, right? And then we saw heroin really taking off, and we really thought heroin was just going to keep exploding. And we started seeing heroin take off because around 2010 is when the government finally started to say, uh-oh, gotta do something different. So we suddenly started talking about not prescribing so much, ridiculous amounts of oxycodone, and that we really should have a better plan for that, right? And so anyway, so then there started to become a gap, and of course that didn't take long to get filled in by heroin. So, but instead of heroin really just maintaining this huge surge, something cheaper and more potent and more addictive and more deadly came along, right? So in fact, it's really hard to find real heroin, just so you know. Like if you were looking to use some heroin, it's hard to find. And people who are still using real heroin as opposed to something that's really fentanyl made to look like heroin, like mashed together other stuff, dirt, make it look like heroin. If you have a source, people are very secretive about it, because they don't want anybody else to move in on their little stash where they get real heroin. But now heroin, the deaths from heroin have just plummeted, right? Because it's hard to find. And so we're back to where a heck of a lot more people are dying from oxycodone again than dying from heroin. And a lot of folks fear methadone, like, oh, methadone, that's such a dangerous drug, And but you can see that there's a lot fewer people dying from methadone, than oxycodone, right? It really is much safer, used properly, prescribed, people in treatment, right? But this is the story, of course. This is what's exploded. So just to kind of move this slide along here. So fentanyl analogs, that's what it means. Of course, oxycodone, hydrocodone, hydromorphone. But you know what you don't see on this graph? Buprenorphine. Okay, so buprenorphine is what's often referred to by the brand name Suboxone or Subutex, different chemicals. There's many other products that we use. We use a lot of injectable buprenorphine. We use it in many ways, in many formulations now. But, because it's really hard to hurt yourself with buprenorphine. We'll talk about that in just a minute. You really got to work at that, okay? So unless we're talking about, unfortunately, giving it to a very small child or something. But anyway, this is where we are in New Mexico. So as of 2013, by the way, in 2013, the state of New Mexico, as we had been for many years, we led the nation in overdose mortality per capita, right? So then, in 2014, we were finally bumped from the #1 spot because things exploded in Appalachia, right? And so West Virginia is where it really exploded, and West Virginia is still #1. We did really well, kind of dropping down here. But then when COVID hit us and fentanyl hit us, because remember, it comes across the border, so fentanyl really hit the Southwest first, then things exploded, and we're back up to #6 in the state. Now, Rio Arriba County, of course, I should have brought my state of New Mexico graph, but so Rio Arriba County has more than twice the overdose mortality of any other county in the state, of course. And in fact, Rio Arriba County, for many years, also led the nation, the entire nation, in overdose death. We were still #1 in 2014, in fact, and kind of drifted down, but depending on which source you see, tells you we're somewhere between 5th and 15th, kind of still where we are. We've made progress, or maybe other places have gotten worse, but we really have made a lot of progress in Rio Arriba County, not just for Presbyterian, but a lot of things going on there. I'll talk a little bit about. So these are fentanyl tablets. These are what people call blues. So I don't know if has anybody ever held any of these in your hand? Ever seen these, like real? Right? So this is how it got started. And this M, see this is M, so some people call these M30s. The way this got started is, we first used to see these, they were white before they started getting colored, and started seeing these like around 2016 or so in New Mexico, and the white ones weren't nearly as potent, didn't have as much fentanyl in them, but that M stands for Mallinckrodt. So Mallinckrodt is a generic pharmaceutical producer, right? And so basically someone in the drug cartel of Mexico, they were able to get the stamp for this. So basically this looks exactly like a generic 30 milligram oxycodone tablet. So a lot of people started using these things thinking, no pun intended, that they were getting a smoking deal on some oxycodone. Because normally, that 30 milligram tablet of oxycodone diverted has a street value of about $30. That hasn't really changed much. Oxycodone is still the gold standard if we're talking about sort of the market price of diverted or illicit pharmaceuticals. Oxycodone is still what everybody would rather have more than anything else, believe it or not. So anyway, so it still goes for about $1 a milligram, and so that's each one of those costs you about $30. The thing is, people were getting these for like only $10. They're thinking, what a great deal I have. In fact, I have a number of patients who that's how they got started doing these. But it's very addictive, and people would start out originally swallowing, and then if you've already had a history of misusing oxycodone, you rapidly progress from just swallowing them to chewing them and swallowing them. Of course, you go to crushing them and snorting them, and that's the way you start using them, right? So anyway, the only good thing, if there's any good thing about the opioid epidemic with fentanyl, is that people have getting their veins back, right? Because for so long, we were seeing always heroin, and people were injecting heroin, and you inject heroin because you rarely smoke it, because you don't smoke heroin because it burns up half of it, and therefore you only get half as much that you're spending on. So if you're spending $100 on a gram of heroin, well, you smoke it, you're losing a lot of it, right? So anyway, but you don't need to inject anything, right? You can just smoke it, because you get about 80% bioavailability, meaning most of it you're smoking is going into your body, into your bloodstream, and all you do is roll up some foil, make a little pouch, put a flame under it. I guess the technical term is it pyrolyzes, it vaporizes, and you just snort it right off that, or put a straw that you're just inhaling right over it, right? So it's very low tech, very easy to do. This is what, by the way, we used to see. And then for a while, like in the emergency department, we got to a point where every time we, undress a trauma patient or somebody who's really sick and unresponsive, and first thing we got to do is get them out of their clothes and see what we're dealing with. And these blue tablets would just start spilling out of their pockets, their underwear, their bra, or just funnel over, right? There's socks. But we don't see much of that in Rio Arriba County anymore, at least not in Espanola. Some people still use the blue tablets, but this is what has largely replaced the blue tablets, is this we call fentanyl powder. So patients will often just refer to the powder, right? And they'll often refer to in units. So the patient I was last seeing before I had to head up here, new patient, just came into the clinic today as a walk-in, which is wonderful. Anyway, this is sold by the gram, essentially, or the unit, dollar unit. And so it has a consistency sort of like sidewalk chalk, right? And this, each gram of this stuff is probably as potent, has as much fentanyl in it as about 50 of those blue tablets. So, and to put that in perspective, a gram of this stuff has, it's a gram of junk. It's not pure fentanyl, right? But it's pretty dang concentrated. So if you're using a gram of this fentanyl, and anybody else here in the medical field, by the way? You can understand this? Okay, so you smoke a gram of this stuff, or if you're smoking about 50 of those blue tablets, because the blue tablets on average have about 2.4 average milligrams of fentanyl in them. That's 2,400 micrograms of fentanyl. But they're completely random. We see so many people have overdoses because there's no quality control, right? This isn't made in a pharmaceutical company. This is made in open-air vats. And the reason they make them in the open air is because when the cartels make this stuff, if they put them inside like a warehouse to do it, everybody has to wear like a scuba gear practically, because otherwise all these people were dying just from breathing the air. So it's a messy process. It's really inconsistent. But just to come back to the amount of fentanyl in this, if you're smoking a gram of fentanyl, it's sort of like receiving throughout, let's say you smoke a gram a day. That's like getting an IV infusion of about 100,000 micrograms of fentanyl in the course of the day. So to put that also in perspective, Española Hospital probably doesn't go through 100,000 micrograms of fentanyl in a month. Now maybe Press Downtown or UNM goes through 100,000 micrograms of fentanyl in a day. That's for an entire major hospital, right? That's how much these patients are getting, and that's why it's just so challenging to treat. One of the reasons. So it costs about $100 per gram. That's the current market price. And by the way, I get updated on the market price every day when I talk to my patients, so just seeing the guy, I was seeing right before I came up here. And so anyway, the way we generally refer to it, patients refer to it in the kind of dollar units. How much you got? Like I bought a dub, I'm using a dub. It's $20, which means about 0.2 grams. Obviously, you get a better price if you buy in bulk, right? The bigger volume you buy, you do get a volume discount. So, like 3 dubs, $60 worth. So that's just a brief thing about fentanyl and why we're doing this. But this is what I really want you to know, is that MOUD, which is an abbreviation for medication for opioid use disorder, which is what we initiate, and that is primarily buprenorphine, but that also includes, of course, methadone, right? Another important medication, and for some patients, a medicine called naltrexone. But if you lump that all together and just under the heading MOUD, so this saves lives, right? It saves a lot of lives. And if you compare this to patients, and this is, by the way, this is what we call pre-fentanyl data. In other words, this was the mortality risk and the benefit before fentanyl ever came along, right? So the mortality gain is that much higher right now that so many more people are dying from this, and it's so much deadlier and more addictive, right? So if you think of just even in the pre-fentanyl era, right? So untreated patients who don't get access to this medication, they have a 2.5 times all-cause, mortality. They have an over 8-fold overdose, mortality risk, right? And these folks are often young people, and so a whole lot of the mortality we see from opioid use disorder is often a lot of young people dying. Although we do have people with opioid use disorder of all ages. I had a couple octogenarians in my methadone clinic before. So anyway, so this is, like I said, unbelievably life-saving of a very lethal disease. So put this in another kind of graphic perspective. Imagine the green is sort of the baseline, right? Let's say our expected mortality for the population of a given age is 1.0, right? This is what we expected mortality. This is how people die if they don't have treatment, and this is the reduction in mortality, over 60% mortality benefit. And once again, this is pre-fentanyl data. That the last kind of I've read is sort of like it's really now more to be like an 80% mortality reduction benefit from getting people onto this medication if they're untreated. So for any of the physicians in the room, I'm going to ask you, please name one medication, just name one, that doesn't have the word insulin in it, that has this kind of mortality benefit for the disease it treats. And I will tell you just ahead of time, you're not going to think of one, right? So I mean, this is a disease that's not so hard to treat, but yet we put a lot of barriers in the way, but a lot of them related to stigma and other issues, right? So this is unbelievably life-saving, life-transforming, right? I mean, this really is, you give people their lives back. So, but I want to just briefly, I'll zip through this about why it's so much harder now. So it's not just that fentanyl is so addictive, and it is, which by the way, fentanyl is an amazing medication, right? And until it escaped into the world of illegal drugs, this was a really important medication. It still is a really important medication that we use on the ambulance, in the OR, in the emergency department, in the ICU. It has really important properties. It is short-acting. That's why we use it. We can titrate it. It doesn't cause drops in blood pressure, and that's because it doesn't release histamine. It's the histamine release of hydromorphone and morphine and such that put patients at risk for dropping their blood pressure so much. It doesn't do that. So it preserves blood pressure. It's very effective. It's rapid onset, short-acting. We can titrate it. And all these great properties, right? But the challenge is that's the way it works when you use it clinically, when you use it in the right sense, when it's used by a healthcare professional, when a nurse is administering it, right? Or it's getting administered by the anesthesiologist or whomever, right? So we think about this. This is what makes it addictive, the rapid onset, short duration of action, right? But it no longer does that when you use this kind of volume, right? So I told you using a gram of fentanyl, and that's not uncommon. That's probably about the average of what our patients say. And I have some patients who use 5 grams of fentanyl in a day, right? Once again, that's like getting an IV infusion of 500,000 micrograms of fentanyl, which once again, is far more than UNM. Loveless and Presbyterian combined administer in one day, right? So think about that. Anyway, but if they use a lot of it, it doesn't function this way, right? Because it's also very lipophilic, right? I think I kind of told you this number. We'll skip that, right? They way more MMEs, by the way, than oxycodone or what they were using in heroin. So one of the challenges is trying to find a medication. If we're looking at what people call replacement therapy, right? If we're trying to find a way to match up their mu receptors so we can give them enough of a medication that we're actually going to manage their withdrawal, right? You got to find something that's got a lot more MMEs than what we were using when we were treating heroin primarily, or oxycodone or OxyContin, right? But this is the big thing. It's very lipophilic. It builds up in adipose tissue, and because it builds up in adipose tissue, one is the skinnier you are, it is easier for us to help you transition to buprenorphine. The more fat tissue you have, the more challenging it gets. But it also means that once patients start to withdraw, they feel they have withdrawal symptoms, but it's hard to give them this medication called buprenorphine because they're still mobilizing all this fentanyl. And so the thing is, it is just so much harder to initiate buprenorphine that we had to become much more sophisticated because we had a whole lot of crazy things and bad outcomes happen when we first started giving people buprenorphine. So we had to get smarter about it, and it took a while. I don't mean us, I mean nationwide. It took a while in different centers trying different things to learn how to do it. And now we have multiple ways to do it, but it's still, I used to travel the country, by the way. I used to be, for the American College of Emergency Physicians, I used to travel the country educating about this, because I was one of the first in emergency physicians to really taking this on. And I used to, all day, I used to talk about, this is so easy, a monkey could do this, blah, blah, blah. And then fentanyl came, and it just turned everything upside down, right? So Anyway, the other thing is fentanyl has a very high mu receptor affinity. What that means is that when it grabs onto that mu receptor, and by the way, when I'm talking to my patients, by the way, my left hand is always a mu receptor. My right hand is always some sort of opioid, right? So the way they connect, by the way, mu receptors exist in your body to interact with endorphins. That's why they're there naturally. It's just that the structure of opioids has enough similar chemical structure that it fits in there like puzzle pieces fit together or the way a key fits in a lock, right? And so it activates those receptors. The thing is, one of the key properties of buprenorphine is not only does it stop withdrawal and cravings and everything, and it doesn't make you stop breathing, and it's hard to overdose on all that good stuff, but what it does is it also binds that mu receptor tightly, so once you're taking your buprenorphine regularly, you're protected because your receptors are bound, and even if you use some heroin or some fentanyl, you'd have to use a whole lot of it to get a real effect from it, right? So it protects people from relapsing, it protects people from overdoses. All this is happening. The problem is that binding of it, that high mu receptor affinity, it's a double-edged sword, meaning that if you give it to somebody before they're withdrawing, it'll bind and it'll kick off their other opioids, and it's fighting for that mu receptors, and while all that activity is happening, while they're fighting for the receptors, the patient's in withdrawal, they're thrown to the stage of precipitated withdrawal. It's going to be pretty miserable. Now, with fentanyl, or with heroin, it wasn't such a big deal, or oxycodone, because that period would be relatively brief, a couple hours maybe, and then the buprenorphine would settle in. Or if it happened in front of you, you just fixed it by just giving them more buprenorphine. Essentially, you just overwhelm the receptors, more buprenorphine, you could fix the precipitated withdrawal real easily. I have a patient in the hospital for the last 5 days, got discharged her today. She was in the ICU all this time because Friday afternoon, she decided that she had relapsed from buprenorphine and fentanyl. She'd been on buprenorphine a while. She had a traumatic event in the family. She relapsed and was going to get herself started on her buprenorphine again. So she thought she would do this the same way she did it years ago when she switched from heroin to fentanyl. She just waited till she was withdrawing a little bit and took a dose of buprenorphine and then went through into a terrible precipitated withdrawal. Thought she would just fix it by taking more buprenorphine because that used to work, right? And that just made her into even more precipitated withdrawal. And eventually she ended up spending a couple days in the ICU as we transitioned to buprenorphine. And this is not uncommon, right? So we never used to see this. We never used to have to admit people to the hospital for their precipitated withdrawal, but now we do. So anyway, So fentanyl has a pretty high mu receptor affinity, all right? So you're withdrawing, it's releasing out of your adipose tissue, the volume's not going down, there's plenty of it around, and it maintains a pretty tight grip. Now, buprenorphine will eventually win that fight. It will eventually pry it off, but while it's trying to pry off that fentanyl and they're fighting for that mu receptor, once again, those mu receptors are not satisfied, and the patient goes into this precipitated withdrawal. And many patients have experienced this, or they've seen this, because a lot of folks, exactly like I described, thought they could do this the way they did it before from oxycodone or heroin, and they wind up in this really terrible precipitated withdrawal, which is prolonged and sometimes puts them in the hospital. And so many patients are terrified of buprenorphine, which is unfortunately because it's this amazing life-saving medication, but a lot of patients are terrified of it, and therefore there was a tremendous increase in demand for methadone because you don't have to withdraw to start methadone, right? So, in the grand scheme of things, thank God there are methadone clinics out there, right? But unfortunately, this happened a lot. So, and I could describe numerous cases of this, some very impressive, some people to the point that we had to intubate them, put them on an endotracheal tube down their throat and put them on a ventilator to get them through this. So anyway, I just want you to understand the challenges of it and why you need to have more expertise, and you have to have a stronger team than you used to have before if you're really going to impact this disease, right? So the other thing is we're just talking about opioid use disorder. There's so much out there. There's such a web of services that you need. Now, there are some folks, all they need to see is the physician and a prescription pad and instructions and start them on buprenorphine, and they do great, right? But that's a small, group of patients, right? Some people need all kinds of services because A, they may have become homeless in the meantime, right? And I know you guys have discussed this, right? But if we think of some of the most common causes, leading causes of homelessness, it's untreated substance use disorders, untreated behavioral health conditions, There's others, right? Domestic violence, right? Other things, and endemic poverty. But those two conditions, which are major causes, and then often people become homeless and then they fall into that, and so it becomes even more self-perpetuating. So anyway, we need folks, some folks need counseling. Transportation services, which we'll talk about, is a big problem. If once you're gone through all your money and you no longer have transportation and you're homeless, fortunately, some of my patients have been able to live in their car for a while until they got into treatment and their car still ran. Good for them, but people need a lot of these services. They need peer support, and we have to focus on stigma reduction and harm reduction, right? This is for folks who are still using. We want to make sure they have plenty of naloxone, they have clean needles, fentanyl test strips. When we say fentanyl test strips, it's not for testing yourself, not for testing your urine, it's for testing whatever it is you were thinking of injecting or smoking, right? So anyway, so there's a lot of services that are needed. This is a slide I put together for Senator Heinrich's office years ago. So anyway, I just want to talk briefly about alcohol use disorder, because even though we treat a lot of other stuff, but we think of what are the two most common things that put people in the hospital and can kill people. The two leading substance use disorders are opioids and alcohol, right? As an addiction consultant, because I saw 4 patients in the hospital today, in the ICU mostly before I went to clinic, and then saw patients, right? The 90% of what I'm being consulted for is alcohol and opioids, right? So, but think about this, right? So 140,000 people. This, by the way, is also pre-fentanyl data. This is like from 2015 to 2019. It got a lot worse during COVID, as you can imagine, right? COVID made a lot of things worse. And with opioids, being combined with fentanyl was just a double whammy. But a whole lot of people with alcohol use disorder, other substance use disorders got really out of control, right? So now in the United States, this is actually, once again, pre-fentanyl, 380 deaths every day due to alcohol use disorder in the United States, right? Kills more Americans, actually, than all drug overdoses combined. It's a major killer. It shortens the lives of people who use alcohol and have an alcohol use disorder by about 25 years. Now, the difference is we don't see as many people dying as teenagers and young adults as we see with opioid use disorder. But still, I unfortunately have had many, many patients, even in their 20s, die of cirrhosis-related complications. But it's so many people die in their 30s and 40s, and it's really sad. And unfortunately, this is where we still lead the nation. So New Mexico, we are still number 1 in alcohol use disorder-related mortality. Anybody want to guess which state is right behind us? Who's second? Alaska, yes, right, Alaska. Okay, trivia question for the day. All right, so, this is an enormous cost, to New Mexico, and unbelievable workplace productivity losses, healthcare, criminal justice expenses, a number of inpatients, people in the hospital who have an alcohol use disorder. It's stunning, right? Because it's such a common co-occurring condition. And the mortality, of course, just got worse and practically doubled almost with the pandemic. Rio Arriba County and McKinley County, we lead the state. Rio Arriba County is, again, number 1. So we have no shortage of patients with another leading substance use disorder that we take care of. This slide actually came out of a presentation because in 2023, Espanola Hospital, we got an award. We got what's known as the Quest Innovation Award, which is given to one hospital in the state every year for making a difference in your community. And we did that because of the way we started treating alcohol use disorder and saving lives and reducing hospital readmission rates and reducing mortality with alcohol use disorder. I think we've made a great difference in opioid use disorder too. It's just such an easier disease to study. The data is easier to pull out. And I can explain that in detail why, but the data is easier to follow. So anyway, so just to briefly talk about this, because alcohol use disorder is another very serious substance use disorder. It infects a whole lot of people. It doesn't, like any substance use disorder, and I can say this, by the way, also as the parent of a daughter with a substance use disorder. It unbelievably impacts family, community, as my wife just says. And by the way, she's much more eloquent of a speaker than I am. But she's, by the way, is the nurse educator, the addiction nurse educator for the state, right? So she travels the state teaching nurses about how to manage patients and work with patients with substance use disorders. Anyway, she always talks about this wake of destruction that substance use disorders leave as they move through families, right? And it really is unbelievable, the loss of income and expenses and stress and conflict and also ultimately often end up leading to homelessness, right? Because it just becomes too hard to have your family member with their severe substance use disorder in your home, unfortunately, stealing from you and having all kinds of things happen at your home, and it becomes so hard, it's exhausting. And you finally get to a point where you're like, I can't bail you out of jail anymore. I can't afford to get you out of jail anymore. I can't, all those things. And it creates such conflict, and it just tears through families. But we can treat alcohol use disorder, and we have multiple medications we use to treat alcohol use disorder. And we make a great difference in alcohol use disorder. We have tremendous turnarounds, much of which facilitated by medication. Now, fortunately, alcohol use disorder also responds a heck of a lot better than opioid use disorder to things like counseling and peer support and 12-step programs and things, right? So with alcohol use disorder, we're all for 12-step programs and similar things, but when we combine that with good medication and peer support, the benefit is just, goes up exponentially, really. So anyway, at Espanola Hospital, by the way, Espanola Hospital, when it comes to treating substance use disorders, we are the pilot. We're the pilot for everything that happens in the entire 9 hospital system, including Press Downtown and Russ Medical Center, our big hospitals in Albuquerque. Everything we do relates to substance use disorders, we pilot in Espanola, right? So we're really the leader. Espanola Hospital is a cutting-edge hospital when it comes to treating substance use disorders, and I mean that nationally, right? So we talk about initiating a medication, naltrexone, as an injectable medication in the emergency department. We were one of the first 5 hospitals in the country to do this. This is another thing I used to kind of travel around speaking about how you do this. So we do this not only in Espanola Hospital, now we do this at Press Downtown, we use at Russ Medical Center, other hospitals do it, but we pilot everything in Espanola. So, So the other things that we do is we've really expanded what we know, and we use more medications to treat cravings, right? It used to be, we didn't do anything, right? How do we treat alcohol use disorder? We get them through withdrawal, we put everybody on benzodiazepines, which are also highly addictive, and then you send them back out, and say, hey, go to AA, go to AA. That was the solution to everything. Well, not everybody likes AA, by the way. Some people love it, not everybody does. There's a lot more peer support type of activities you can engage in, right? So, but this is an important medication. By the way, this medication was not created to treat alcohol use disorder. Most of the medicines we use to treat alcohol use disorder were not created for that purpose. They were created for something else. But this is actually created to treat opioid use disorder. But it's really only applicable and effective for a small kind of slice of the opioid use disorder patient population, right? And I can explain why in more detail if you want to talk about that. But we've found a lot of other medications which are really important and really helpful. But this is one of the most powerful medicines for decreasing cravings for alcohol. And you can give people this injection that lasts for like a month at a time. Doesn't work for everybody, but works for a lot of people. And especially then if you can combine that with other important medicines that we use, like gabapentin. Gabapentin has become like a Swiss Army knife of medicine, in addiction medicine. We use it for a lot of stuff. Acamprosate, important medicine. Topiramate. By the way, this is a medicine that was certainly not created for this purpose. It's an antiepileptic, which isn't used very much as an antiepileptic. Gabapentin was created to be an antiepileptic, hardly ever used for that anymore. We use it for all kinds of other stuff. This is an interesting medication. This medication was the only medication on this list that was created for this purpose of reducing alcohol cravings. But it's kind of pricey, and only in the last few years were you able to prescribe it without even getting a prior auth and everything. So, plus you got to take it 3 times a day. So anyway, I try to get everybody on at least 2 medications. Some people, I put them on 5 medications, right? If you keep winding up in the hospital every week, then I try to be as aggressive as possible with medication as long as I can get them to take it, right? So the good news, none of these are controlled substances. So the other thing, what we don't really do very much anymore is we really try to discourage the use of benzodiazepines. We use gabapentin, by the way. Gabapentin is our #1 medicine, is our primary medicine we use for managing withdrawal. So that's, in fact, I am the medical director for a few detox centers. That is our #1 medicine we use for alcohol withdrawal. We use it as an adjunct for opioid withdrawal, but it's really effective. There's great data showing that. And so it's really cut down on the amount of benzos we're putting people on, the benzos we're prescribing. And then actually we've gone to old school medicine. Our second medicine, the one we go when people are, they're withdrawing beyond gabapentin, we add phenobarbital. So phenobarbital has been around, I think, since like the 1950s, maybe 1940s. I don't know, but that's really become our go-to medication for patients who need more. And we like phenobarbital because it has a really long half-life. It's not very euphoria-inducing, and it's just, when we started using it and kind of looking at the literature and switching things around, and this is what a lot of major centers have moved towards. We try to align ourselves with cutting-edge centers who are, producing good data, having good outcomes. Really made our withdrawal better. But the good thing is also, in 25 years as an emergency physician, I've never once had a patient come to the emergency department complaining of their withdrawal from gabapentin or phenobarbital and like drug seeking for phenobarbital or gabapentin, right? But yet, we still have patients every day come looking for prescriptions for benzos like Xanax. So we're not contributing to another substance use disorder. No long-term benefit to putting people on benzos, by the way. One study has never showed any benefit to that. All you do is give them a new substance use disorder to have to deal with. And I can tell you of all the substance use disorders I treat, because a lot of people come to us specifically to get help, to get off their benzos, this is the hardest thing for me to get people off of. This is harder than treating fentanyl. It's harder than treating tobacco, methamphetamine, cocaine. This is it. So hardest thing to get people off of. So anyway, this is one, we don't use this very often. This used to be used a lot, right? Prescribe people disulfiram, antabuse. Well, you just need to take your antabuse, right? The problem is A, people don't take it, right? So you can prescribe it all day long. But this doesn't take away cravings. It just makes you sick if you drink. Now, this does work in some cases, right? But we've come to learn, well, who does it work for? Well, it only works basically if you've got good patient selection. And here's what I've really learned over time is it only works if they have a bond, they have an obligation, a covenant with someone else in their life that they are going to take this medicine for, right? It's not enough to take it for themselves. They need to take it for their wife or their parents or somebody who's tolerated their substance use disorder who is going to let them stay home, essentially, if they take their medicine. And it can't be punitive. You have to counsel them and say, your job is to make sure, that Jane or Joe takes his disulfiram every day, right? So anyway, we've brought this back into the fold, but you really have to know who you're using it with. It also has some toxicity issues with it. So anyway, we don't use this very often. We use a lot of this now at Espanola Hospital. We connect people to peer support. So peers are people who have been, have suffered from substance use disorders and they are in recovery, right? So as we talk about this to patients, these are people who have walked in your shoes. And they're so important because it's so hard to talk. If you have a substance use disorder and you crave and you get triggered to use and you withdraw, it's so hard to talk to anyone about it who hasn't lived that, right? It's so hard to explain to somebody how you don't know what happened. You were just driving home from work and before you knew it, you're in a liquor store and it just happens. Or you just pulled off and went to the dealer and you can't explain why it happens, right? So, but you have to be able to talk to people who have lived experience. So this has become a really in-demand field. We finally hired another one today. We've been working to hire more, and they're in great demand. We try to hire people who've actually gone through a training program in addition to having a lived experience. So, by the way, this was a big challenge when we first started bringing these people into the hospital, because if you've had a substance use disorder and to the severity that you can really help people because of your lived experience, the vast majority of our peers, part of their lived experience has involved the criminal justice system. And that used to be a no-go. Can't hire anybody to work in a hospital. Well, you mean you got a felony, That was so we spent 6 months changing our HR requiremements. So, okay, well, what if none of their felonies were violent crime? Okay, what if we just make sure they haven't had these offenses, right? Because most of their criminal offenses were being charged for theft, right? And or distribution or prostitution, right? Anyway. But this has really been a great addition. They really help our folks, especially early on in their treatment. We can prescribe medication. They're there to help them, making sure they're taking their medicine, connecting to other people, getting them to their point of stability. So they really do work closely with our folks. So anyway, they also help them get connected to other peers, right? Because we soon will have 3 peers. We're on our way to 4 at our hospital. We had 1 for a long time. And But he couldn't be everybody's peer. He couldn't be everybody's sponsor, right? So you have to connect people to other groups. There's a lot of folks out there that would like to be sponsoring somebody. So this is our original peer. He's still with us. He's been with us for 6 years. His name is Ronnie Flores. He's from Española, and it's interesting because he talks about how many times he himself was brought into that emergency department either after an overdose or under arrest, and had kind of been through it all. And so he's actually turned into this really amazing role model. So he's great. So we just wish we could clone him. We knew we have one more, and we just hired another one. We're on the hunt for another now. So, but the one thing that I will say, I said a lot of things, sorry. But, what makes all this possible, by the way, is the culture at Española Hospital, meaning that wanting to make a difference in how we manage patients with substance use disorders. This has been something that our CEO, who's lived her whole life in the area, has worked at this hospital for 38 years. It is so important to her. Our CMO, you may not know this, but if you worked, I'm like a recovering hospital administrator, right? And the average, how long a CEO at a hospital normally lasts? It's usually less than 2 years, right? If somebody's 5 years, the CEO of a hospital, that's like unbelievable, like almost like what's wrong with you? How come you didn't get a better job at a bigger hospital and move on? So. It's she's been there her entire career. She's been the CEO there for like 15 years, right? And our CMO, he's worked his entire career there. He's not from here, but he moved here, and he's worked his entire career there. So anyway, when I first showed up at the hospital, started working there, it was like November 2018, and Fernando Bayardo is his name, and he said to me, he says, never did I ever think I'd see the day when we actually had an addiction specialist on staff. And so we went through, a lot of things, finding out what worked, what didn't, and I was still splitting my time with Santa Fe Medical Center and such, and now I just work there. But it's been so amazing the way the staff of the hospital have really gathered around this idea. And this is like a key driving force for our hospital's mission, is to make a difference in this patient population, which, as you know, has been a challenging patient population in that community for a long time, right? But we really are making a difference, and we're committed to this. This is a big part of our strategic goals. This was like just some data that we put together just for following alcohol use disorder, and we could show what a difference we made in people coming back in the hospital, and reduced visits in the emergency department and hospital readmission. I don't want to kill you all that data, but that's why we won that award, because we were able to demonstrate that. But we've taken this on in all of our patient care areas, right? So for example, when it comes to opioid use disorder, we initiate buprenorphine in the ICU, in the emergency department, in our progressive care unit. We initiate buprenorphine in labor and delivery. We manage alcohol use disorder in all those areas as well. So we get consults. We go there. We now have our consult service running 4 full days a week, which is great. And we see where the patients are. And whenever there's a patient in labor and delivery, that's where we go first, of course. So, but this is supported not just by myself and like the folks involved in their care, but this has become a major theme of being a hospitalist. We're not going to hire you as a hospitalist. We're not going to hire you as an emergency physician now to work at our hospital if you don't value making a difference in this patient population. It's become a theme of being able to work at our hospital. If you have a problem with stigma, if you resent this patient population, then you're working at the wrong hospital. And you usually won't stay there long. And it's really, I've done so much work with our nursing staff too. In fact, we've done so much provider education through our physician leadership support, tip sheets, FAQ guides, order set building, and just lots of education. But the other thing is our nursing leadership is absolutely committed to this. From our CEO, who used to be the CNO, our CNO, all our nurse managers, ICU, labor and delivery, our clinics, right? So many of our clinics feel comfortable at least managing stable patients. But we invested a lot, right? So basically had a nurse educator, an addiction nurse educator, come up to the hospital, and when she was contracted by Presbyterian, so Presbyterian, contracted with her to come and do these workshop sessions at all Presbyterian hospitals, right? And so most hospitals, they got one session of a 4-hour workshop with whichever nursing staff could attend, right? So, and then, it was way too many staff at Press Downtown or Rust Medical Center to do that, so instead she created all kinds of online modules, right? But the most effective way was when you get people in the room and you talk this out. It's very emotional. There's a lot of issues. I mean, years and years ago, I used to ask people, hey, does anybody know somebody, in your family or a coworker with a substance use disorder? And then I learned after a while that was a dumb question. Like the question I ask now is there anybody who doesn't have a family member, a colleague, a coworker, or personally has struggled with a substance use disorder, right? I mean, it affects almost every family one way or another, right? So anyway, our CEO saw this and participated in this, and then immediately contracted separately to have her come back 5 more times to do 5 more classes. And then brought her back a couple years later, right after COVID started to settle down. And she's coming back. Again, we have grant money we got to use up. Grants are weird, right? You don't always get to spend it the way you want it. Sometimes you have a deadline to spend it. So we make sure we invest it all in education. So anyway, they're bringing the nurse educator back. She's going to do like 10 sessions with the staff this time. Very interactive. It's really amazing. So, but we're doing all these things. We focus on all this in our pharmacy. Pharmacists at Española Hospital are so great. When we talk about what we're doing, they're so used to doing this. They think it's fascinating. Sometimes I get curbside consulted by the ICU docs that press downtown, and I'm trying to help them, start something, and then the pharmacist will call me and ask me, what are you doing? And I explain what we're doing. Well, I've never seen this. And I'm like, oh, okay, we're going to get there. We're going to get that hospital fixed too. So, but here's what I really want to talk to you about, and I know I've yammered on way too long, and I appreciate once you get your patience, and I'm sorry if I put a few of you to sleep. So, but I just want to give you kind of a background of kind of what's happening. But this is what's exciting now, right? So moving forward, by the way, I'm only going to have like 4 more slides, but does anybody desperately need to get up and like go to the bathroom? Y'all good for 4 more slides? Okay, good, thank you. So this may not look like much, but this is the renewal clinic, right? So that's what we call it, the renewal clinic. The big thing is, it has its own parking lot. Do you know how cool that is? At your hospital, if you have a clinic that has its own parking lot, that's exciting. It has its own access door, right? It's got the doors right in there. And the space is huge, right? This is the old emergency department. So the emergency department, if any of you ever went to the emergency department prior to about 10 years ago at Española Hospital, you would have been seen in this space. So it's a big space, right? So the whole space now is dedicated to behavioral health and addiction medicine. So we make it easy, so patients don't have to navigate, kind of the system and checking in at the information desk and then getting sent down to registration. We do it all in one place now. We're still waiting to open. I say this, we're doing this because we've been ready to open this place for 6 weeks now. We're just waiting on a state inspection. It's killing us. What is it going to take? And it's so funny, the governor wants to be there when we open, Senator Heinrich's office wants to be there when we open. It's well, can't any one of you important people, get the inspector just to come up and just get this done? First floor, you don't have to go up steps, and it's great, separate entrance. We're trying to make this low barrier and easy. We want to make this so easy for people to just walk right in the door and be seen by a clinician. To see one of our nurses, our medical assistants, or our peers, because we're all in the space together. It's exciting. We've got lots of space to grow. All the rooms are enormous, by the way. They're all big rooms, that you would be wheeling in, a stretcher, a hospital stretcher, a hospital bed could go in and out of the doors, and there's room to do all that we would do as if each one of these rooms were still in the emergency department. The trauma bay, we still have the trauma bay, which was all prepared to provide critical care to 2 patients. So it has what we call the critical care tower. That just means basically a whole bank of outlets and oxygen tubing and oxygen and airflow and suctioning. We still have both of those in the trauma bays, right? So we're still waiting for the hospital to finish renovating the OR. We might have to have patients who are going to the PACU, that stands for Post-Anesthesia Care Unit, getting done after they have surgery, they have to recover, and so part of our clinic might become the PACU for a couple months till they finish that renovation. So we haven't moved the critical care towers out of the way yet, they're still there, but we still have a massive room. Eventually we get to divide that up. All these rooms, it's room to grow, right? Each one of these rooms could be cut in half, and we just add more doors, so it's exciting. Some rooms don't even have full walls around them yet because we just don't need it. We had to find a way to get the whole thing open and meet the inspection. It still required an investment of about $400,000 because the whole room had to be completely gutted essentially, right? Because it was old. All right, so this is what our service was, right? Until 2 months ago, that was one physician, that was me, 0.6 FTE. We had 1 peer support worker. We didn't have any of our own dedicated nurses or medical assistants. We borrowed everybody from endocrinology clinic. We've been moved around the hospital 3 times, different spaces, And fortunately, the endocrinologist had space in their clinic, so they let us move in there. But it is now Grand Central Station in there. It is so overcrowded because we have all these new folks joining us, and we're packed in there. So we only had the clinic open 8 hours a week. It was only open Monday afternoon and Wednesday afternoon, and trying to see all these patients was challenging. The consult service ran for about 12 hours a week. That was where we'd see the patients in ICU, med-surg, emergency department, labor and delivery, who need an addiction medicine consult, and go help them get into treatment. So now, by October, right, this is like a month and a half, right? We're getting so close, right? We'll be up to 4 physicians. That's 2.5 FTEs. I'm still looking for another 0.6 FTE. I still got money. I got grant money to hire one more person until the government pulls it or whatever. Dr. Jessica Gregg, she just joined us. Everybody, by the way, so far we've hired is from New Mexico, which is pretty exciting, or is moving back to New Mexico, so it's really cool. Dr. Gregg, many years of experience, initially trained in internal medicine, been doing addiction medicine, 15, 20 years, coming to us from Oregon Health Sciences Center. She's actually one of those MD, PhD types. It's pretty exciting. Anyway, she's fabulous. We were just working together today in clinic. She's already started. The patients love her. We have our next docs joining us, Dr. Margaret Fox. She's also local, coming up from Santa Fe. She's a pediatrician. So she's taking her addiction medicine boards in the fall. She basically trained under me for about 6-7 months and then worked at the Mountain Center. The Mountain Center, we're going to incorporate all their patients in our practice and be better, more efficient in the community so they can do the stuff they do really well. Then we have Dr. Chance Nahera. He grew up in Carlsbad, lived around the state, and did his residency at UNM, just finished his addiction medicine fellowship at UCSF, University of California, San Francisco, a great program. So we're going to have this really great eclectic group, but he's also family medicine trained. He's going to do half-time family medicine primary care, half-time with us. And I'm still on the hunt for one more. Dr. Fox as a pediatrician with Dr. Nahera. So Dr. Gregg, she was internal medicine trained. What that means is you take care of sick adults and you don't take care of kids and you don't deliver babies, right? So anyway, she's not really going to help us with the pediatrics, but Dr. Fox, and she's really going to head up our adolescent program and really help us improve our care of newborns again. Espanola Hospital really used to set the bar for the management of newborns in withdrawal for rural hospitals. And then COVID, fentanyl, lost one of our key docs, lost our key pediatrician, and so now we ship a lot of those babies. Meaning we transfer them down to where there's a neonatal ICU, like at Christus, or down to Press Downtown, or down to UNMH. And the problem with that is the baby gets good care, but when we transfer that baby, we lose mom. So by keeping the babies, we get to keep mom. And that's the most important part about that. So we're on the hunt for another 0.5 FTE or 0.6 FTE. We've got Jasmine Sanders. She starts in 4 weeks. And this is great because she's been a nurse practitioner about 5 years, doing some addiction medicine. She's going to be able to hit the ground running. We're going to train her. We're still going to mentor her. But for 11 years, before she became a nurse practitioner, she was a neonatal ICU nurse. So it's a great fit. We're hopefully going to sign another one. We're interviewing some folks, hoping to get there soon. We're soon going to have 4. We just signed a third. We're going to get to 4 peer support workers. We already have 1 nurse and 2 MAs. We're hiring more. And we're still looking to hire a program director and a nurse case manager. We finally posted this position, and a nurse case manager. So, because a lot of our patients need a lot of case management resources, right? So this is where we're going to be. So here's our goal. The renewal clinic is going to be open 40 hours a week, usually with 2 providers at all times. And what this gives us, it makes us so we can do walk-in hours. We're going to always have room for walk-ins. Just walk in and we're going to see you. Or you call, we will give you an appointment this afternoon or tomorrow. We're going to make sure that we can see people when they're discharged from the hospital, within a couple days. By the way, until we start doing this, there was so much demand for our clinic. We have people driving from 2 hours away. A lot of patients coming up from Santa Fe. There's just a lack of resources in Santa Fe. We have some people who still come to see us from Albuquerque, but we have a lot of patients who come from Los Alamos, actually, and from Taos, and people from Red River, Raton, Chama. Anyway, So to get a new patient appointment in our clinic was taking 7 weeks. That was as soon as we had for a new patient. And if you have a substance use disorder, and today is the day that you decided you want help, it just doesn't work very well to give you an appointment in 7 weeks. I'm always amazed at like the 30% of people who actually kept that appointment for their first appointment. It's pretty amazing, right? So anyway, treatment room. We'll be able to just start people on medication. We're connected to what's called our infusion center. We can then get them over there. We just had a meeting on this today. Our new nurse, she's already going to get cross-trained in both areas, so we can start giving people long-acting injectable medication the same day. The peers have their own room. They're going to be right there in the clinic with us. We see a patient, we want to connect them to peer support. They're just going to come right over, talk to the patient, and they're going to have visits of their own. We'll have some patients who just come back just to see the peers. So we're all going to be together, and then we're doing this. So it turns out we were trying to figure out how we were going to get a van together. And I will tell you, as we were pondering this, is also when we started talking to Dr. Taylor, who started asking about this, and then the Presbyterian health plan started taking a great interest in what we were doing, and we started talking about where we want to go. We've got to find a way to get to the homeless shelter, and it's really hard to work out of the homeless shelter itself. It's really difficult for a variety of reasons structurally. I said what we really need is like a clinic on wheels we can take down there. Turns out Presbyterian owns one of those things. So as soon as we're fully staffed, then we're going to start taking by the way, it's the size of like one of those big touring buses, one of those like massive RVs, right? You have to have a CDL to drive the thing. It's big. So it comes with its own driver. It's got a couple exam rooms, got a little pharmacy, its own little lab area. So what our plan is to start taking this down there first like twice a month, and then hopefully every week. We want to take it right down to the middle of Española, where we're going to be closer to the homeless population. And we may keep moving it around until we find the best site. The problem is the homeless shelter, it's hard to park it there. And then there's unfortunately, I wish that I could say that all of our city government felt the same way about accessing patients with substance use disorders that we do at the hospital, because they keep wanting to break up those homeless encampments. But we like all the homeless to be together in an encampment. It reduces the rate of drug overdose, and it also makes it easier to get them into treatment. It's really nice when they're there, and we can just pull up the bus and bring the clinic to them, right? So hopefully, as we start doing this, we can then meet again with the city council and kind of maybe change their minds about, because just because they scatter your tents, it doesn't make you not homeless, right? It just means now you're back to sleeping under a bridge or farther out in the woods or some other doorway, right? So anyway, we also are going to be providing telemedicine services. So the patient I saw today was actually just referred to us from, I hope you all know this abbreviation. This is the clinic that's up in TA, Las Clínicas del Pueblo de Rio Arriba, right? Anyway, they just referred him, and he lives up in Chama, and he came down to see us today, and so we squeezed him in, and I'm sorry I'm late. So anyway, but we're going to be doing telemedicine at these rural clinics. He actually could get down there today. That was the thing, right? Because a lot of these rural clinics, like Las Clínicas del Norte, they have a clinic. They actually have a small, I guess, FQHC up here in Los Alamos, but they have a clinic in El Rito and in Abiquiu and in Ojo Caliente. And a lot of patients, they can get to that clinic, but it's harder to get all the way down to Española. And if they don't come into the clinic, they often don't have cell service out there, and they don't have internet service. So even if we wanted to do like telemedicine to their cell phone, to their smartphone, it's really hard, right? So but if we can get them just into that clinic that's a lot closer to home, well then we can, by video, we can see them. And we'll do the same thing with the Hickory Apache as well. So we're going to eventually, hopefully, provide telemedicine, addiction medicine support to all these clinics providing primary care, and actually get them connected to a board-certified addiction specialist and our team, right? So anyway, I repeated that slide just for you. So what we do need is, we really need more homeless shelter spaces. The homeless shelter goes ups and downs. Like I said, hopefully we can change the minds and get some better function there. It's in a great spot. If you want a homeless shelter in your city, right? We need a real functioning detox center. We still don't have that. But now that we have the staffing and the expertise, hopefully maybe we can help the one we do have and help them, raise the bar and provide a better service, right? We just met with the folks at OI. Anybody familiar with OI Recovery? So it's a program out there in, it's between Alcalde and Velarde up there. And, they have a really great tract of land. They have nice buildings, they have really good physical plant. and lots of cool programs. The problem is they've struggled always to have like a nurse supporting or have a provider to be able to have people maintain on medication. So now that we are staffing up, we just met with them last week, and we're going to work on a process that we'll just be the ones to provide the medical care, and we'll work with telemedicine with them too. We'll get them on site so that we can get them to maintain people on medication. Because once again, everybody does better if they have access to medication, right? So, and we have tried this over the years actually to support them. It just was too hard. We just didn't have enough providers and to do it. So that's one of our goals. Looking to improve transportation. Dr. Taylor and his group have been great about pressuring the city and trying to come up with some options and hopefully get phone access. It's interesting, like we meet with the Presbyterian health plan folks and they say, hey, but if you got this health plan, if you got Medicaid, you can call and you can get a travel arranged, but you got to call them 3 days in advance to get you to your clinic. The problem is, it works sometimes, but let's say they get you to the clinic, well, they usually wind up running behind, and they only allow the patient to go be seen for 15 minutes, because then they got to get back so we can go, take people to the next clinic. And so it's our patients who come this way, they're often so stressed. You got to get them through their visit, and it's not very good for doing a behavioral health or substance use disorder visit if you give your patient 15 minutes, right? Only for the patients who are really stable, and at that point, they probably don't need the ride program so much anymore because now they have transportation, right? So it's particularly not good if you're homeless or phoneless, right? So anyway, so we're working on phone access. So now that we're getting staffed up, we were just talking about this in our staff meeting. It's about time to start working on this and rolling this out. There's a whole bunch of references, sorry. Okay, that was a long talk, but I just want to let you know. Now, I will tell you that a lot of people ask me, well, how secure is this? Because there's two big grants that fund all this, right? So one of them is known as the New Mexico Rural Healthcare Delivery Fund, and that is provided particularly funding we use it a lot on capital improvement, and we've used it to give salaries for physicians. And then the grant decreases over 3 years because the idea is that after your clinic's up and running, you don't need the salary support for the physicians. It's really meant to be seed money. But the SOAR grant, which stands for State Opioid Response, which is delivered to the state, to BHSD, Behavioral Services Division, as a division of HCA, which used to be called Human Services, right? So that comes through SAMHSA. And as you know, or maybe you don't know, but one of the goals of the Trump administration is to get rid of SAMHSA because we just don't need that. Why do you need people to have better access to mental health or substance use disorder treatment? So anyway, the funds will still come to the state. We don't know how much are going to come. We'll know hopefully at the beginning of the fiscal year, but it's a real mystery. So we're trying to adapt and looking for other funding sources. We are meeting with the county and the city. They are sitting on a fair amount of opioid settlement funds, they've actually been telling us for months. They've just been waiting for us to deliver a budget. And as soon as they got those funds or notification of those funds, they came to us a long time ago and said, how can we do this? And we were just able to secure these other funds. And they've been kind of saying, well, when you know what your needs are, come to us. The county in particular said, we're going to try to help bat clean up on your unmet needs. So we are going to be meeting with them soon because we're going to say, we don't know what we're going to need, but we're somehow we're going to need somewhere between the difference of $0 and $866,000 the next year, somewhere in there. So, but we're just we've been maintaining this dialogue for a while. Okay, sorry I've talked for so long. Any questions?
Oh, yeah.
I used to be the recovery room nurse in Los Alamos, and I gave a lot of morphine every day for terrible pain the patients were having. And I wonder what you do for that pain now.
Well, I think we're much more aggressive about treating pain, but hopefully treating pain in a better way. As you may know, one of the great contributors to the opioid epidemic was hospitals. And, in addition to folks being pressured by the government to prescribe more opioids out of the clinic, right? But in fact, we used to have these campaigns, right? To satisfy Joint Commission and the such to show that you were going to make sure that nobody had their pain untreated. That's how we came up with the pain score number, because you had to be a way of quantifying that we were giving enough opioids. In fact, we used to have these slogans like we've got more pain medication than you've got pain, right? So I'm not kidding, right? This was a big part of Quint Studer training on how to improve your hospital's customer service scores, right? So many of the metrics, I'm not kidding, I say this as a former emergency department medical director for years, and former chair of the Department of Surgery at a good-sized hospital. Metrics were driven around making sure, like a patient goes to the emergency department, if they had a long bone fracture, you were measured in time to first opioid administration, right? That's the only way they measured pain management. Didn't have anything to do with whether you splinted and reduced the fracture or did all those other great things that were more important, but the only measure they came up with, time to IV opioid, and if you were a child, you could get an oral opioid. But if you didn't get an opioid, there wasn't a way of saying patient refused. I'm not kidding you, it was really crazy. But one of the challenges we have now is, right, if you have an opioid use disorder, well, it means you've also got a tremendous opioid tolerance. And so we've actually worked a lot with our anesthesiologists and our recovery team, to better manage, patients' pain who has an opioid use disorder, opioid dependence. So, and that includes for patients who are treated with methadone, buprenorphine, naltrexone. So we developed a strategy for that. So one of the silly things that people were doing for a while, and I know because I had to meet with the anesthesia group 8 years ago, 9 years ago at San Juan Regional when I was working there. And, they had to have this plan. They wanted everybody to come to the OR taking off their buprenorphine. Because, we're not going to be able to administer opioids to them if they're on buprenorphine, right? It was a great myth. And so then you'd take people off their buprenorphine and put them back on oxycodone, which is how they got in that mess in the first place, and you destabilize them. And guess what? They showed up in the OR in a lot of withdrawal. And now it's really hard to control their pain. So we're much better about that now. Now, we got a patient call, to our clinic today, asking our nurse, who's going to be our lead educator for our patients. One of the questions is, should I get my Brixadi injection tomorrow? That's a sustained release depot form of buprenorphine, because I'm going to have surgery in 2 weeks. Is it safe? And it was the most important thing was, yes, absolutely get your buprenorphine. We don't take people off their buprenorphine anymore. If anything else, we've learned how to train the staff to one of the best medications you can use to treat their pain post-op is actually more buprenorphine. It's a very potent analgesic. But learning much more about multimodal pain management instead of just giving people more and more opioids, right? So, yes, ma'am.
Hello, thank you for this great talk, and thank you, Dr. Taylor, for organizing it. I'm Jessica Strong. I'm with the County Social Services here in Los Alamos.
Okay, great.
And Jeremy Martinez, who works with me. Will your peer support specialist be connecting with Rio Arriba County or others if there's issues related to homelessness, food instability, all of those social determinants of health?
So a couple things on that, right? So fortunately, the city of Espanola finally established a Department of Health and Human Services. I don't know if you know Michelle Frere. It's a department of one person. But the Rio Arriba County has had some resources there for a while. Unfortunately, Ms. Reichholtz, I can't think of her first name, was no longer there, because she was a driving force for developing all those programs, right? It'll hit me as soon as I walk out of the room. They are investing their opioid settlement funds and expanding those services as well. But part of the reason we are getting a nurse case manager is we want to make sure that we are connecting people to the other resources out there. As we met with the Mountain Center folks, and they have all these cool services they provide that we don't provide at the hospital, right? And we want to make sure that we're connecting people to those. And it just is an economy of scale issue. They've decided since we're hiring Dr. Fox away from them, they've really decided that it's been too hard to maintain a provider program and said, we don't need to. We'll do that, but we just need to work closely together for all these other services. So, we want to have a better communication. Our peers so far, just to clarify the question about what do peers do. So some peers view their job strictly to be that person to provide counsel, to provide emotional support, shared experience, encouragement. But all of our peers do a lot of case management. They're really good about connecting people to residential treatment, in fact, for patients who want to do that. But but sometimes we overburden our peers with making them provide case management services, which is why we're trying to bring on a case manager. And so if a social worker, case manager applied, we'd probably entertain that. But the truth is we just have a much harder time hiring social workers than nurses in a case manager role. So we assume that position will probably be filled by a nurse, a case manager. I think we're listing it both ways, but that's probably who we'll end up hiring. Hopefully from within, I hope. But anyway, yeah, no, we try to, connect people to more services. We can't do it all, from the hospital. Even though we're providing, nurses and providers and doing what we do well. I mean, what we should do well is manage withdrawal and initiate medication, but we want to work with the community. So hope that answered your question. But it's good to know that you have more services up here, because we have a lot of patients come down from Los Alamos currently, and we'd like to get people connected too. So.
I have a question and then I just have a little comment.
Okay.
We've got a severe shortage of psychiatrists in New Mexico.
Yes.
And I might have missed it, but are you going to have a psychiatrist on
Well,
staff?
we have the funding to have one, and we thought we had one hired just a week ago. We thought we had a verbal agreement and that she was going to take the job, but then she ended up taking a job in Colorado. We were so bummed. But yeah, part of the funding from the Rural Healthcare Delivery Fund is to pay for the salary of a psychiatrist. So that's a position we haven't filled yet, but once we hire a psychiatrist, we then want our psychiatrist to be involved in the other positions we intend to add. We intend to add a psychiatric nurse practitioner or PA to assist our psychiatrist. A lot of patients needing medication management, right? And then we also want to hire 2 master's level trained counselors, so either LPCs or LCSWs, but that's all part of the plan as well. I've been doing so much, other behavioral health medication management for a while. I've had to learn how to manage eating disorders and other things I never thought I'd be doing. I won't say I'm good at it. I just didn't have another place to send them that I could get them in less than 6 months sometimes. We have had a little more collaboration with your North Star group up here lately and getting a few more patients up here. But that can be challenging for our Medicaid population. So, but yeah, that's our goal, is in the same space. We have enough space in the old ER, because it's a massive space, that we had planned to also have a psychiatrist and eventually counselors and our a psychiatric APC working there. And when we hire all those folks, then we'll begin the next phase of upgrading, or not upgrading, but renovation, which is closing off these rooms that are like open rooms and dividing some of these big rooms in half. And the trauma bay, that could easily be divided into 4 patient care rooms. And I don't think we need to preserve any of it for meeting room space. So.
My little comment is, as the Interfaith Coalition has gotten, we've done more. We realize that in the Espanola Valley, there is not a real understanding of medically assisted treatment. And there's an attitude with some people that feel like that's just a crutch. You need to be on it and get off of it, because it's another drug. So. Yeah,
that happens everywhere. It's a progressive process of educating folks and changing it. So, for example, years ago, when patients, would go to NA, Narcotics Anonymous, right? In fact, a methadone clinic I was working in used to hold NA meetings. But you have to be really selective to find out who's leading your NA meeting, because there are some folks leading NA meetings who are preaching that you have to get off that medication, that you're not clean until you're off the medication. By the way, I hate that word clean, by the way, because the opposite, of course, implies dirty. I hate that word, but so I think we're making a lot more progress, but there are still some folks, including some people who are peer support workers, that unfortunately are encouraging people, that you should need to get off medication. We're actually, one of the groups I'm now starting to meet with a lot more is Inside Out. The great thing is Inside Out has the parking lot where we're going to park that bus. So I think we've been making some progress and changing, because they have some folks who've worked there who still have that perception. But it does take time to change that perception. You got to change that perception with judges, right, and other physicians and providers. I'm going to tell you just a sad story about that. that very issue, and this, affected my family. So my niece, wherever she is, if she's alive, her name was Dana, and this was actually, I guess, my step-niece. My younger sister remarried, and her husband had 2 children, and when she went off to college, she was going to Fort Lewis College in Durango, and like many young people at the time, this is, 8 years ago or so, well, she started using heroin, and at the age of like 20 or so, and my younger sister viewed this as a scandal. It was so important that the family didn't know. And then when I found out, and this was actually right before I was about to go and testify for the U.S. Congress as an expert, and I approached her and talked about the importance of getting her a medication, and blah, blah. And well, eventually she did get on a medication, and she was treated with buprenorphine. And 6 months later, I was talking to my younger sister, and I said, hey, how's Dana doing? And she told me how great she was doing, in the sense that, well, Dana's, she's got a job, she's maintaining a job, she's back to school, she's got her own place, she's really doing well, except she's on Suboxone. And I said, you mean that medication that saved her life, that's enabled her to be able to get back to school and maintain a job again and all that? And I said, this is a great gift. I mean, this has saved her life. But nothing I could say would change my sister's perception, because after all that, her response was, yeah, but she's on Suboxone. Once again, this is the medication that's, yeah, but she's on Suboxone. I mean, it's as if this was a scandal for the family as opposed to the medicine that saved her life. Anyway, a couple years later, she became a missing person. And so I, doubt she's alive, buried somewhere probably. Unfortunate, but this happens to a lot of people. When I was working in a variety of clinics, several times I'd met with families, because unfortunately, the most common folks who want to pressure people to get off their medication, off their methadone, their buprenorphine and such, are often family members, spouses, parents. And I remember once I was working in the methadone clinic in Farmington, and this young man, who was actually somebody my son had gone to school with, really hit rock bottom and developed terrible opioid use, started using heroin. And we got him into the clinic. And we stabilized him. He was doing really well on methadone. But his family was insisting, that he get off that methadone, and just because it's methadone, right? And it didn't matter that it had saved his life. And so I met with his parents, and no matter what I could say, trying to sum up how he can now have a normal life and blah, 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 and but he's on methadone. Yes, but again, this medication that has saved his life and blah, blah, right? And so they really forced him off methadone, and of course he became homeless again and developed a lot of problems, but then eventually he came back into our clinic, and I was able to meet with his family again, and now they had a completely different perspective. And I'd asked him, I said, so what was he like when he was on methadone? And I talked about how normal he was. I said, so we're going to keep him on methadone now, right? You're not going to pressure him to get off. No, we'll never do that again. I was just fortunate that he survived that. But yeah, there's a lot of pressure out there. I think it's getting slowly better, but we have to invest in that. One of the major barriers to care is just stigma, right? I mean, that is the major barrier. So many, unfortunately, we really have to roll the red carpet out for some patient populations in particular, right? Pregnant women. One of the major barriers to pregnant women getting treatment is being terrified of walking into the clinic and being looked upon that they've committed this horrible crime, the fact that they're, using and they're pregnant. And so they're afraid of having their babies taken away, afraid of going to jail, all these things, so they don't come and get treatment. Right? And often getting, flack from their families and other things. So it's an area we really need to invest in. I would say that probably in the pre-fentanyl era, half the patients I started on buprenorphine would come into my clinic, and they'd been using diverted buprenorphine, maybe like for 2 years or so. And finally, they came in to get their treatment official, like they actually have it. And they were so nervous, in this visit, and because it took so much nerve just to walk in the door and be willing to talk about it, because we've, made it such a crime, And so the big thing that we really try to do now when our patients come into our clinic and we talk about is we got to give them hugs and high fives, and we just have to acknowledge how hard it was, that first step. So often when I'm talking to a patient, and I always want to know who they live with and like who their partner is. I said, okay, so your partner, blah, blah, well, tell me about your partner. And I'll ask, does she use or does he use, and where is your partner? Well, she's in the car, I said, well, go get her, I mean, this is crazy. We'll start you both on treatment, because if you live with somebody, especially if you have an intimate relationship with somebody who's still using and they're not in treatment, their probability of success goes way down, right? So, we always have to inquire, but we always ask, who do you live with? Is anybody else using in the home? Because then we have to think, how safe is your medication? How likely are you to get triggered to relapse? So, sorry, I can talk about this all day. I've taken up the whole evening.
So
I should shut up now. I'm sorry.
I think we have
So-
2 more questions that I know. Are you okay with that? There's
Oh yeah,
there's some water up
I can
there.
just keep yammering on. I'm just. I'm sorry, I just don't want to keep you all here too late.
This isn't a question.
Yes,
but
ma'am.
It's a thank you. I'm Kathy, the founder and executive director of Inside Out Recovery.
Hey, Kathy.
Hey. And I just want to thank you because we've been working with addicts for 7 years.
I know you have, and by
in
the
that
way,
valley.
Kathy should stand up and take a bow.
No.
By the way, no. This is really done amazing work just out of the goodness of her heart. And I love your new location. I love the fact that you're in that shopping center, and the fact that you have that other group that just moved in next to you, that recovery group, and the fact that it's going to be a great place for us to park our bus. So we're really excited about that, and we need to get together more again. But I'm just really glad that Ronnie and such has been communicating with you all, and it was really good to see you for the first time a couple weeks ago. I hadn't seen you in a few years in person, so.
Thank you. I really, truly am thanking you. I feel like crying because we've waited 17 years driving people to Santa Fe and Albuquerque trying to get help. I love your attitude. I love that you accept peer support.
Oh, absolutely. We
and
just
that
wish we could get
you
more.
love our people. Thank you.
In fact, if you could give us more peer support workers, we're all looking for them now, right? Like they're hard to find, because they're in such demand. Isn't it wonderful that a peer support worker is a high demand field now? And amazing that is, right? Like now, like you have to compete with other agencies, to hire. You can like pick your job now as a peer support worker. That wasn't the case even like 5 years ago necessarily, right? So we're all making progress. By the way, I just want to give a shout out for Inside Out. This doesn't happen. Rio Arriba County didn't like move out of the #1 spot, for overdose mortality because of one group alone. This is the work of groups like Inside Out. This is the work of Rio Arriba County's, Rock Stop program, of changes in approach to criminal justice, and the work of like Judge Lydiard and the El Centro clinics. So it's really great that we're collaborating more. We have 2 methadone clinics now in Espanola. We also only had 1 for a long time. I'm glad they're now starting to have to compete on customer service. That's been long overdue. Yes.
I just wanted to let you know we're offering full harm reduction at Inside Out. So when you park there, we have full harm reduction.
That's wonderful. That's great. Good to know. And I will be over again soon. I'd like to see a full tour of your new place. That other place you had, you were so packed in there. So it's great to see your new location. You have much better space. Yes, sir.
So I'm afraid to ask this question because I think it'll. There's so many complexities that
sure, that's okay.
So it has to do with alcohol versus opioid addiction, and you mentioned that alcohol is, it's for 1,000 years we've had problems with alcohol addiction, and society seems to be more accepting of that. So I wanted to ask you about the percentage of your patients that have one versus the other, and more importantly, the stigma of one versus the other, and whether there is a path there to reducing the stigma for opioid and alcohol by
Yeah, so, the
sympathy
stigma
between those.
changing process, it requires continued reinvestment, re-education, which is why, if you haven't met Brenda Romero, the CEO of our hospital, this is a woman with an unbelievably big heart, right? And she acts like a secret shopper, like going into like pharmacies to try to figure out what the struggles patients have in filling their prescriptions, right? And she has family members who are affected by this as well, and she's, bends over backwards, to help them. But this has been something she's been wanting to do for so long. I think opening this clinic and expanding the service will probably be the capstone of her career, and then I hope she doesn't retire because of it. I hope she stays with us. She deserves to retire, but I hope she stays longer. But yeah, this requires work. This is why she's brought back the nurse educator who specializes in reducing stigma. That's the main goal of her work, is to reduce the stigma that we have as healthcare providers, right? And particularly working with the nursing staff, right? Because it's easy to understand why the nurses would logically, resent patients, more than the physicians would, right? Because they have the difficult job for years of starting IVs in people with no veins. And when you're withdrawing from opioids, guess what? You're not usually on your best behavior. And so I had to tolerate a lot of, difficult patients. And so, we've worked to, adapt that, get better technology and ultrasound. We've trained all our nurses to start IVs in our ultrasound now. But really working on that stigma, so that by bringing her back every couple of years and doing all these workshop sessions again, every different, it keeps changing every year when she comes back. It's a whole new program. But that's but it requires that reinvestment. When we were told, that we have a certain amount of the grant funding that we were going to be able to carry over to the next fiscal year, but because of the Trump administration and doing away with SAMHSA, basically we've been told, use your grant funds now. Don't plan to be able to carry it over. We don't know if you'll still have access to it if you do. So the immediate response was, well, what's the most effective way to use this funding? It's educate, right? The expense of educating is paying 240 nurses to spend 4 hours plus of training, right? That becomes a big bill pretty fast, right? As well as paying your providers to attend hours of training. Dr. Greg and I are each going to be running multiple substance use disorder classes on different topics, and the nurse educator is actually going to do a special 1-hour session on bias for the providers. And she does a great job of it. So when I used to teach on this topic for the American College of Emergency Physicians, the truth is she wrote my lecture, so it was better. So anyway, yeah, it requires investment. It doesn't happen on its own. Like anything, the culture of an organization, organizational culture doesn't maintain itself, right? You have to invest in it and reinvest in it and reinvest in it. Otherwise, you just let a few people with bad attitudes, kind of sour everybody. We deal with this all the time when we have travel nurses or locums physicians, that come to our organization, and you can see how they start to resent this patient population and the challenges they have of being homeless or having a substance use disorder. And we have to call them out on it right away, and we have to work to change that attitude. We had a travel nurse, and I think she's already enlightened quite a bit. She came to us from Tennessee. I worked with her about 3 or 4 weeks ago in the emergency department, and she was talking about this patient. So this patient, you could tell she just, in where she worked before, the goal was to get this patient a sandwich or something and get him to leave. And she was talking about what he was doing, and she says, he says he picks up cigarette butts off the street to smoke them, and he's even eating roadkill, blah, blah, and I'm hearing about this patient. I said, boy, it sounds like he really needs some help, doesn't he? So then it was a really busy night, so I didn't get to see him for a couple hours. He was sleeping, and he came in, he was sick, he was throwing up, and probably from something that he ate, maybe. But anyway, so I sit down with him and find out he's lived in this community for 6 years. And he moved from Tennessee to this area to take a job with whom? Los Alamos National Labs, where he worked for 3 years until he started using methamphetamine. And then he and his wife both started using methamphetamine, destroyed their marriage, they fell apart, they both became homeless, and they separated, and she lives in Albuquerque somewhere, but, just because you work at a place like Lanel doesn't mean can't be a victim of a substance use disorder. So anyway, yeah, he was there a long time, and we did what we could to help him. He mostly spends his time in Santa Fe to try to get him connected to services there. But once again, to answer your question, so then I was hoping he was going to stay in Española, because I knew that Michelle Frary from Española Health and Human Services, is now doing a lot of work to transport patients, because we do have a sober living area. We have resources now that we didn't have in Española long ago, right? But and so we started talking with this nurse, and it wasn't just me talking to her, it was our other nurses, talking to her about, that's not the way we treat patients here. We want to connect those people to help. Our job is not to just, get them to leave the emergency department. So anyway, sorry, I could talk about this all day, as you can see. I should let you all get some rest.
Thank you so much. We really appreciate it, Eric. I said to people before you arrived that, you know, there's these multiple things that the Interfaith Coalition is working on, and there's just so much positive happening now in Espanola Valley, and this is a big chunk of it, but we're seeing it on multiple fronts, so everybody keep that in mind. Good night, everybody.